All living things reproduce. Reproduction is the process through which life continues to exist. In sexual reproduction, two individuals produce offsprings that have genetic characteristics from both the parents. Sexual reproduction introduces new gene combinations in a population. Unlike the male, the human female has a reproductive system located entirely in the pelvis, that is the lowest part of the abdomen. The female reproductive system consists of the ovaries, accessory structures such as uterus and the external genitalia. The female gonad, the ovary, is responsible for both gamete and hormone production, just as the testis is. Females are born with all the oocytes they will ever have. Oogenesis. Egg formation takes place in the ovaries. In contrast to the males, the initial steps in egg production occur prior to the birth. Diploid stem cells called oogonia divide by mitosis to produce more oogonia and primary oocytes. By the time the fetus is 20 weeks old, the process reaches its peak and all the oocytes that she will ever possess, that is approx 4 million of them, have been formed. By the time she is born, only about 1 million of this remain. The others are eliminated by apoptosis. Each has begun the first step of the first meiotic division, stopping at the diplotin stage of meiosis I. No further development occurs until years later when the girl becomes sexually mature. Then the primary oocytes recommence their development, usually once at a time and once a month. The primary oocyte grows much larger and completes meiosis I, forming a large secondary oocyte and a small polar body. In humans and most of the vertebrates, the first polar body disintegrates, but the secondary oocyte does possess as far as metaphase of meiosis II and then stops. Entry of the sperm restarts the cell cycle. Completion of meiosis II converts the secondary oocyte into a fertilized egg or zygote and a second polar body. The second polar body, like the first, degenerates. During the reproductive years, eggs mature and are released from the ovaries in a cyclic fashion. They move through the reproductive tract by the contraction of smooth muscle or the beating of the cilia. This process occurs roughly once a month for about 40 years. Fertilization occurs in the fallopian tubes. If fertilization takes place, then the embryo develops into a fetus and ultimately to a fully developed child over a period of about 9 months. If no fertilization takes place, then after about 2 weeks, the dead egg is expelled out of the uterus through vagina. This process takes place over a period of about 3 to 7 days. This clears the way for new batch of eggs to come in the uterus. The whole cycle from egg production to the expulsion of egg takes about 4 weeks. This cycle is known as menstrual cycle. Female reproductive cycle, that is called menstrual cycle. Females produce gametes in monthly cycles. These cycles are commonly called menstrual cycles because they are marked by a 3 to 7 days period of uterine discharge known as menses or menstruation. The menstrual cycle is described according to the changes that occur in the follicles of the ovary and in the endometrial lining of the uterus. The ovarian cycle is divided into three phases: the follicular phase, ovulation and the luteal phase. First, follicular phase. Day 1 of menstruation is day 1 of a cycle. Just before beginning of each cycle, gonadotropin secretion from the anterior pituitary increases. Under the influence of FSH, several follicles in the ovaries begin to mature. As the follicles grow, their granulosa cells under the influence of FSH and their thecal cells under the influence of LH start producing steroid hormones. Thecal cells synthesize androgens that diffuse into their neighboring granulosa cells, where they are converted to estrogens. Gradually increasing estrogen levels exert a negative feedback effect on pituitary gonadotropins, thus preventing development of additional follicles in the same cycle. At the same time, estrogen stimulates secretion of estrogen production by the granulosa cells. This positive feedback loop allows the follicles to continue estrogen production despite a decrease in gonadotropin stimulation. As the follicles enlarge, the granulosa cells secrete fluid that collects in a cavity known as antrum. The antral fluid contains the hormones and enzymes needed for ovulation. Some follicles undergo atresia. Only one dominant follicle in the ovary will continue to ovulation. In the uterus, menstruation ends during the early follicular phase. Under the influence of ovarian estrogen, the endometrium begins to grow. There is an increase in cell number and enhanced blood supply to bring nutrients and oxygen to the thickening endometrium. During the late follicular phase, ovarian estrogen secretion reaches its peak. At this point of the cycle, only one follicle continues developing, while other follicles degenerate. At the end of the follicular phase, the granulosa cells of the dominant follicle begin to secrete small amount of progesterone in addition to estrogen. Estrogen in the late follicular phase exerts a positive feedback effect. Immediately before ovulation, high levels of estrogen aided by rising levels of progesterone create a surge in gonadotropin releasing hormone secretion by the hypothalamus. This enhances the pituitary responsiveness to GnRH. Pituitary secretes a surge of luteinizing hormone. Luteinizing hormone surge is an essential part of ovulation. Without it, the final step of oocyte maturation cannot take place. During this period, the meiotic division of the oocyte resumes. With this division, the primary oocyte expels the first polar body and becomes an egg. These follicles grow in size, ready to release its egg during ovulation. The high levels of estrogen in the late follicular phase helps prepare the uterus for a possible pregnancy. Before ovulation, the thickness of endometrium becomes 3 to 4 mm. Cervical glands secretes thin mucus which helps the sperms to pass through cervix. Ovulation. Ovulation occurs at around middle of the menstrual cycle, that is on 14th day. About 16 to 24 hours after LH peaks, ovulation occurs. The mature follicle gets ruptured. The antral fluid along with the egg is expelled out. The egg is swept into the fallopian tube and carried away to be fertilized or die. The alert surge causes the follicular cells, that is granulosa plus thecal cells, to transform into the luteal cells of the corpus luteum. This process is known as luteinization. The luteal cells accumulate lipid droplets and glycogen granules in their cytoplasm and begin to secrete progesterone while estrogen synthesis decreases. Luteal phase. After ovulation, progesterone is produced in increasing amount by the corpus luteum. Estrogen levels increase but never reach the peak as seen before the ovulation phase. These hormones exert negative feedback on gonadotropin secretion. Under the influence of progesterone, the endometrium becomes secretory. The endometrium continues its preparation for pregnancy. Endometrium cells deposit lipid and glycogen in their cytoplasm. Other effects of progesterone is the thickening of cervical mucus. Thicker mucus prevents the entry of bacteria and sperms into the uterus. If there is no fertilization, the corpus luteum degenerates into an active structure called corpus albicans. Production of estrogen and progesterone decreases. The decreased levels of these hormones remove the negative feedback signal to the pituitary and hypothalamus. As a result, FSH and LH secretion increases. Maintenance of secretory endometrium depends on the presence of progesterone. In the absence of fertilization, the rising level of progesterone inhibits the release of gonadotropic releasing hormone, which in turn inhibits further production of progesterone. Corpus luteum degenerates and the progesterone production goes down. Blood vessels in the surface layer of the endometrium contract. Without oxygen and nutrients, the cells die. This results in shedding of the endometrium as menstrual bleeding 11 to 16 days after ovulation. There are few clots of blood in the menstrual flow because of the presence of fibrinolysin, a substance that breaks up the clots. Now, let us talk about the hormones. The hormones that are responsible for reproduction come from two sets of glands, and as a group they are called the gonads. In the female, they are the ovaries. The most important hormones made by the ovaries are known as female sex hormones, and the two main ones are estrogen and progesterone. Estrogen is involved in the development of female sexual features such as breast development, the accumulation of body fat around the hips and thighs, and the growth spurt that occurs during puberty. It also contributes to the maturation of reproductive organs such as the uterus and vagina, making them ready for pregnancy. Estrogen promotes growth of the mammary duct system. The other hormones, progesterone, causes the uterine lining to thicken in preparation for the pregnancy. Together, progesterone and estrogens are responsible for the changes that occur in the uterus during the female menstrual cycle. Progesterone is required for normal implantation and maintenance of pregnancy. Progesterone also prepares the estrogen primed endometrium for implantation of the fertilized ovum. During pregnancy, progesterone prevents abortion by suppressing the myometrial contraction of the uterus. Menopause. In women, the cessation of reproductive cycles is the time known as menopause. When a female approaches her late 30s, her ovary starts making less estrogen and progesterone, the hormones that regulate menstruation. These changes become more pronounced in her 40s. Her menstrual periods may become longer or shorter, heavier or lighter, or more or less frequent until eventually her ovaries stop producing eggs and she may have no more periods. On an average, women experience the menopause sometime around 51 years of age, although it is often a few years earlier or later. Menopause is complete when a female had not had a period for 1 year. This is called postmenopause. Women who are postmenopausal can no longer get pregnant, but in the months or years leading up to that point, she might experience these signs and symptoms, and it can take the body a while to adjust to the changing hormones like irregular periods, decreased fertility, vaginal dryness, hot flashes, sleep disturbances, mood swings, increased abdominal fat, thinning hair, etc. As menopause nears, the ovaries no longer produce adequate amounts of estrogen and progesterone. Hormone replacement therapy for women in menopause consists of either estrogen alone or estrogen and progesterone in combination during and after menopause. Hormone therapy helps to replenish the estrogen, relieving some of the symptoms of menopause and helping to prevent osteoporosis. This treatment continues to be controversial because of a possibility of increased risk of breast and uterine cancer. Alternatives to hormone therapy. Hormones are not always needed to reduce symptoms of menopause. There are many steps that can be taken to reduce the symptoms. Diet control. Caffeine, alcohol and spicy foods should be avoided. The female must eat a balanced diet that includes a variety of fruits, vegetables and whole grains, and that limits saturated fats, oils and sugars, and she should get plenty of calcium and vitamin D in food or supplements. Other than this, she should practice relaxation techniques and exercise regularly. Female infertility. The primary symptom of infertility is difficulty getting pregnant. Various causes of infertility may result in additional symptoms. There are various problems that can cause infertility. Ovulation disorder. Ovulation disorder account for infertility in 25% of infertile couples. This can be caused by flaws in the regulation of reproductive hormones by the hypothalamus or the pituitary gland, or by problems in the ovary itself. In an ovulation disorder, the female ovulates infrequently or not at all. Abnormal FSH and LH secretion. The two hormones responsible for stimulating ovulation each month, that are follicle stimulating hormone and luteinizing hormone, are produced by the pituitary gland in a specific pattern during the menstrual cycle. Excess physical or emotional stress, a very high or low body weight, or a recent substantial weight gain or loss, for instance 10% of the female's body weight, can disrupt this pattern and affect ovulation. The main sign of this problem is irregular or absent periods. Polycystic ovary syndrome, that is abbreviated as PCOS. In PCOS, complex changes occur in the hypothalamus, pituitary and ovary, resulting in overproduction of male hormones, that is androgens, which affects ovulation. PCOS can also be associated with insulin resistance and obesity. Luteal phase defect. Luteal phase defect happens when the ovary doesn't produce enough of hormone progesterone after ovulation. Progesterone is vital in preparing the uterine lining for a fertilized egg. Premature ovarian failure. This disorder is usually caused by an autoimmune response where the body mistakenly attacks ovarian tissues. It results in the loss of the eggs in the ovary as well as in decreased estrogen production. Damage to fallopian tubes, that is tubal infertility. When fallopian tubes become damaged or blocked, they keep sperm from getting to the egg or close off the passage of the fertilized egg into the uterus. Endometriosis. Endometriosis occurs when tissue that normally grows in the uterus implants and grows in other locations. This extra tissue growth and the surgical removal of it can cause scarring, which impairs fertility. Cervical narrowing or blockage, also called cervical stenosis. This can be caused by an inherited malformation or damage to the cervix. The result is that the cervix can't produce the best type of mucus for sperm mobility and fertilization. In addition, the cervical opening may be closed, preventing any sperm from reaching the egg. Uterine causes. Benign polyps or tumors in the uterus, common in women in their 30s, can impair fertility by blocking the fallopian tubes or by disrupting implantation. Unexplained infertility. In some instances, a cause for infertility is never found. It's possible that combination of minor factors in both the partners underlie these unexplained fertility problems. Diagnosis and treatment. An important first step in diagnosing female infertility is figuring out whether ovulation is occurring at predictable intervals. When an egg is released, it causes a shift in the body's sex hormones. The temperature remains slightly higher during the second half of the monthly cycle. This shift in sex hormones can be detected using a precise thermometer called a basal body thermometer. An ovulation predictor test is an over-the-counter urine test that can predict egg release. This test checks for high levels of luteinizing hormone. A positive test near the middle of the cycle means it is likely that the female has ovulated recently or are about to ovulate. The vaginal mucus can also be examined at home. With careful instruction, some women are able to interpret changes in the appearance of the vaginal mucus and consistently of the cervix as a sign of hormone shifts that show ovulation has occurred. After the doctor examines the vagina and pelvic organs, a sample of mucus from the woman's cervix and vagina may be treated for possible infection. If necessary, blood test also can be used to confirm normal ovulation by measuring a high progesterone level in the later part of her menstrual cycle. Blood levels of two additional sex hormones, that is follicle stimulating hormone and estradiol, can help show that the ovaries are functioning well enough to release the eggs. These blood tests usually are done at specific times in the menstrual cycle. Other blood tests may be needed to measure the function of thyroid, pituitary and adrenal glands. Other tests that are used to understand the cause of infertility examine the physical structure of pelvic organs. A hysterosalpingogram is an X-ray study done after a liquid X-ray dye is allowed to flow into the uterus through a slender catheter positioned just inside the cervix. The dye outlines the shape of the uterine cavity and reveals problems such as polyps, fibroid tumors or other variations in the shape of the inside of uterus. The dye also flows through the fallopian tubes and can reveal problems such as partial or complete blockage. An ultrasound reveals the shape and size of the uterus and gives some information about the uterine cavity or inner lining. This test cannot determine if the fallopian tubes are blocked. An ultrasound can identify the ovaries, their shape and size, and the presence of developing cyst. Hysteroscopy and laparoscopy are surgical procedures performed by a gynecologist. Both the procedures use a small video camera to view the pelvic organs. The gynecologist can see the inside of the uterus during a hysteroscopy procedure, can obtain biopsies, and in some cases can remove polyps, fibroids or scar tissue. Laparoscopy allows the doctor to view the outside of the uterus and to examine ovaries. Sometimes it is possible to remove cyst or scar tissue from an ovary using laparoscopy. When a couple's difficulty in getting pregnant is caused by a fertility problem in women, an explanation for her infertility can be found in about 4 out of 5 cases. It is important for the men in the couple to be checked for fertility problems too. Treatment. Treatment depends on the results of the infertility evaluation. Some causes of infertility have a specific treatment such as surgery to remove a fibroid tumor or medicines to treat a thyroid problem. Infertility associated with infrequent or absent ovulation often can be treated with hormone medications called fertility drugs. All fertility medications have potential side effects and can cause twins or even more than 2 babies in one pregnancy. Most fertility treatments require the supervision of a fertility specialist. Examples of fertility medicines include drugs like clomiphene citrate, injectable forms of luteinizing hormone and follicle stimulating hormone. After fertility drug treatment, the eggs that mature in the ovary can be allowed to travel naturally into the uterus if the fallopian tubes are healthy. Sometimes surgery is used to harvest the eggs that mature after fertility drug treatment, so they can be fertilized with greater certainty in the laboratory and then placed into the uterus. Procedures that can help to start a pregnancy include assisted reproductive technologies, that is called ARTs. The major ART procedure include in vitro fertilization, that is abbreviated as IVF, intrauterine insemination, embryo cryopreservation. Less commonly used ARTs include gamete intrafallopian transfer, which is abbreviated as GIFT, and zygote intrafallopian transfer, that is abbreviated as ZIFT. If none of these procedures prove successful, gestational surrogacy may be considered in the case of women with healthy eggs who cannot carry a pregnancy to term. Older women may require donor oocytes in order to become pregnant.
In this lecture, we have covered the female reproductive system, process of oogenesis and female reproductive cycle, that is menstrual cycle. The menstrual cycle was described according to the changes that occur in the follicles of the ovary and in the endometrial lining of the uterus. It also explored female menopause and what signs and symptoms she experiences in the months and years leading up to that point, and in the end, the causes, diagnosis and treatment of female infertility were discussed.